Hello, and thanks for joining me for this Mental Health Playbook, WPS Local Policy, and Billing and Coding Article webinar. This is the third of 12 sessions in our Mental Health Playbook series. This series is designed as an entry-level introduction to Medicare outpatient mental health services. My name is Mary Muko. I am a specialist in the Provider Outreach and Education, or PO, department at WPS, and I'll be your host today. I am joined by my friend and colleague, Karen Curtis, who will be working behind the scenes and giving me those great questions that you're dropping into the chat. Before I get started, I do want to remind you to review the disclaimers that I have placed at the end of the PowerPoint presentation. They're actually in the slide notes. There are details on slide 48 that you should be aware of. The information that we plan to present today is current to the best of our ability, but it is subject to change. Please refrain from recording any portions of this presentation. We are recording it and will publish it on our Encore Presentations webpage, where it will remain for about 60 to 90 days, and we'll also publish that video recording on our YouTube channel. If you do not wish to participate in this recording, you may leave the webinar at any time. You will also find at the end of the PowerPoint presentation the CPT copyright notice. It is on slide 49 of your presentation materials. Your continued participation in this webinar does infer that you agree to the terms of that copyright notice. So let's get started with this Mental Health Playbook, WPS Local Policy, and Billing and Coding Article webinar. I do want to remind you or mention the CMS Medicare Learning Network, or MLN, is an important part of our education. It is on the MLN webpage, that's on CMS's website, where you can find links to many Medicare learning resources, not just mental health, but a lot of things. In their internet-only manual, publication 100-09, that's the Medicare Administrative Contractor, Beneficiary, and Provider Communications Manual. It is Chapter 6, and it's titled Provider Customer Service Program, where CMS states that the MACs must use CMS National Educational Materials like cms.gov, their website, MLN products, and the MLN Connects newsletter in our provider outreach activities. So one MLN product that we wanted to make certain all of you know about as we're moving through this mental health series, this mental health playbook series, is an MLN product that Karen and I do plan to refer to throughout this series. It is titled Medicare and Mental Health Coverage. You can see some of the topics taken from the products table of contents listed here on this slide. We did mention this publication during our webinar advertisement, and we provided the link where you can access this booklet in case you'd like to refer to it or follow along during any of our webinars. Today we'll mostly be looking at the policy and the billing and coding article that WPS has published, but we do want to make you aware of the great information that CMS has out here in this publication. Here is the agenda and the objective for today. Of course, our objective is for learners to receive an entry-level introduction to Part B Medicare, or Original Medicare, that is, outpatient mental health. And today's focus is on the WPS Local Coverage Determination, or LCD, sometimes we just call it the policy, and the billing and coding article that is a companion to that local coverage determination. Now, this agenda should look very familiar, as these are the exact same topics that I identified in the webinar description when you registered. So during this session, I'm going to tell you why medical necessity is important, and I'm going to provide an overview of both our local coverage determination and the billing and coding article. The name of our policy is Psychiatry and Psychology Services. So let's talk medical necessity. Why is medical necessity important? It is Section 1862A1A of the Social Security Act that actually states that no Medicare payment can be made under Part A or Part B for items or services that are not medically necessary. So this is really overarching criteria for Medicare payment. It needs to be medically necessary. Medicare administrative contractors, or MACs, will determine that an item or service meets medical necessity requirements if the service meets all of the criteria here on this slide. It must be proper or needed for the diagnosis or treatment of a medical condition, provided for that diagnosis, direct care and treatment of a medical condition, and of course, an important part of that is that it meets the standards of good medical practice, and that services are not mainly for the convenience of the patient or the provider. So when I talk about medical necessity to people, I remind them that there, of course, are other conditions for payment. So I call those otherwise covered by Medicare. So in addition to being medically necessary, the item or service must be otherwise covered by Medicare. Well, what does that mean, right? Well, some examples of otherwise covered by Medicare are included here on this slide. Of course, the claim must not be a duplicate. It must meet statutory requirements. Statutory requirements are laws. It must be submitted correctly and submitted by someone who's eligible to provide the services, someone who's enrolled in Medicare, and then of course it needs to be an eligible beneficiary also. We would expect that the service be correctly coded. And then of course there's more things that fall into this otherwise covered by Medicare, including those edits and audits within the claims processing systems. CMS actually defines a local coverage determination, or LCD. It is also in the Social Security Act, this time in Section 1869 F2B. Why do I say that? Yeah, because a lot of people have sometimes asked, well, where does it say that? So we like to provide those citations for you. And one thing that we at WPS like to do is embed links to those resources within those Medicare publications that we publish, resources, articles and such, and even those presentation materials like the ones you received or you were able to download today or within the last few days for this presentation. So anytime you see the kind of a blue colored writing with what looks to be an underline, that's actually an embedded link, and I just clicked on that with my mouse and I'm showing you what happens when you do that. I actually have two monitors open and a lot of windows, so it actually opened on my other monitor, but I'm pulling it over to you so that you can see that section of the Social Security law that I'm actually talking about. I rattled off Section 1869 F2B, so you would look in Section 1869, you would find F and 2 and B, and then you would be able to find what it is or where it is that I've found the information that I'm passing on to you. So Social Security Act. So in that law, it does state that an LCD is a determination by a MAC regarding whether a particular item or service is covered on a contractor-wide basis. In other words, it defines medical necessity for the item or service written about in that particular LCD. I got a couple of pre-submitted questions, and a couple of them were those that I answered this morning when I started working. And the gentleman asked me about policies and changes to policies. I want to make it clear that when you are viewing a policy on CMS's website in their Medicare coverage database, I'm going to go to the policy here. I've got a lot of windows open, as I mentioned. Here's that policy. Make certain you're looking here under the contractor information to see who it is that wrote that particular policy and who it applies to. In this case, this is our policy L34616, and it is written by WPS, or Wisconsin Physician Service Insurance Corporation. Okay, and it covers all of these states for these Medicare contracts. We have contract numbers, we also have jurisdictions. These are just simply some identifiers. Now, if you're out on the CMS website and you're looking at another policy that doesn't have WPS here, and you are rendering a service within jurisdiction 5 or jurisdiction 8, that's WPS's jurisdictional states listed here in the policy, you would not follow that guidance that's written by another Medicare contractor. You need to follow that local coverage determination for only WPS if you are a WPS provider. Now there are national coverage determinations, and you can find those also out here in the Medicare Coverage Database, or MCD, sometimes we call it. And national policies or national coverage determinations apply to everyone, not just a particular jurisdiction like 5 and 8. That is our jurisdiction. So just something to be aware of. And when you look at a policy, sometimes it's collapsed like this. So you'll need to go up and choose or click on that header in order for it to expand. Okay. You can also collapse it, of course. You can do that up here where it says collapse all, or you can just click back on the header. Okay, so some important information to know. Local policies pertain only to the contractor that wrote the policy or published the policy. Now there are different reasons why we develop local coverage determinations. Some are shown here on this slide. Maybe there's a new technology and we need to define our coverage parameters for that new technology that's being used. Maybe it's a service with an abuse history or potential, and this is based on our data. Or maybe it's a service that's billed often or billed with a very, very high dollar amount. So we choose to develop that local coverage, and it's really just local guidance for you. We say local because it pertains only to WPS. Now, we can't just willy-nilly decide to develop and publish a local coverage determination. We have to have the data to back up the reason for creating one. We do have to follow specific CMS directives during that development process before we can submit that LCD to CMS for their approval to publish. Now, if you've ever attended one of our educational sessions about LCDs, you will also know that our contractor advisory group and the public have an active voice in the LCD process. So when that policy is a draft, we take comments from the public, and we do welcome you and recommend that you take a look at those publications or those notifications that we make to the public saying, hey, we're developing an LCD on XYZ. If it pertains to you, you have an active voice in the development of that policy. We have held previous webinars that talks about development of policies. This is just kind of an entry-level introduction, but if you want a deep dive, you can look at or look for some of those great recordings that we have. I think they're great, available out on our YouTube channel. All about policy. We recently held a Medicare Education Expo Day where the only topic we talked about all day long was policy. Why do we develop it? How do we develop it? What are the steps in the process? So what happens when we activate a policy? When this policy goes through that development process as described and required in the Social Security Act, CMS provides instructions to the MACs. We've taken all of those necessary steps, including reaching out to the public to get those comments. Once a policy is published for review and made final, what a policy really means is edits. Policies equal edits. It means that there are edits that are set into place to ensure that the claim being submitted meets the medical necessity criteria for payment. That's described in that LCD. That LCD explains the coverage and the indications for payment. The companion article, we call it the companion article, sometimes the article. Some people just call these the billing and coding guidelines. It's a separate document that's really a companion article. It's a companion to the policy. So you need to really look at both. You shouldn't look just at the local coverage determination or the billing and coding guidelines. You need to use them together. Okay. Now some edits require or are automated. Let me back up. Some edits are automated, and most of the edits in our claims processing system are automated edits. The claims processing system really looks for the information on the claim that's going to confirm the medical necessity of that item or service billed based on what you're placing on that claim. Now, some edits require complex review, and this means that we must render a manual review of documentation in order to determine if that item or service meets medical necessity as described by the LCD. Now, one example of this would be when a provider uses a not otherwise classified or an NOC code on a claim. I've actually embedded a link in your handout for a helpful resource that addresses billing for NOC codes. It's right here at the bottom of slide 10. There are multiple ways to look up a WPS local coverage determination or coding and billing article, and one way is to use the LCD and article lookup tool on our website. And this offers you with an opportunity, and I'm pulling it open here, to show you the LCD and article lookup tool on our website. This is our home page of the WPS website. And if you look right here on the left side, just under the, our logo and our name, there is a code lookup tool. If you select this radio button and you place a code or a word, like I'm going to say psych, if I can type it right, and you hit search or you hit enter, and then your matches will come up. So you will see there are LCDs and articles that have this word in them. So that's just one way to find a policy. You can also use a CPT code, of course. The database, the CMS National Medicare Coverage Database, is that database that I showed you just a little bit ago when I actually showed you the policy. And I'm just going to go to CMS's website. It's bookmarked here. And I'm going to enter MCD, because I know that that is Medicare Coverage Database. I'm a searcher, not a navigator. I like to search. And then right down here is the MCD search coming up in the results. And this is where you can also use a keyword or code to search for a policy, because all of the MACs have their local coverage determinations inside of this Medicare coverage database. You will not find a WPS policy published in its entirety on the WPS website. Instead, it's our policies, and you can get there, or you can get here from there, from our website, but you'll open a new window and you'll go out to CMS's website. But you can, we house all of our policies in the MCD so that the information is the same all the time. Once upon a time, when we published the articles on our website, CMS also published them here in their coverage database. What happens when we make an update to our web page, but CMS has not yet updated their web page? You see where I'm going with this? There's different information. So we made the choice to, because we have to publish in the MCD, to only publish our policies in their entirety out here on the Medicare coverage database. So that's where you can find WPS policies and articles out in the Medicare coverage database, or you can get there from the article lookup on our website. I've embedded these links here for you on this slide. All right, so really what we want to do today is take a good look at the WPS local coverage determination. The title of this slide is the LCD's ID, which is L34616. If you see a policy number and it begins with an L, that should alert you to the fact that this is a local coverage determination. If this started with an A, that would be that companion article. A is for article, L is for LCD. So I've embedded the link to the policy here. The policy, because CMS tells us, includes all of this information. If you look at a policy that's published by another contractor, it's going to include all of that information. Only their policy, of course, is going to provide for you what that MAC considers to be medically necessary for the item or service described in the policy. So all of the policies are formatted the same. We just have different information within them to provide that guidance for you, that coverage and those indications for coverage. So this is the information that's included in the policy. You have that contractor information. I showed you that, very important. Make certain that you're using a WPS policy or only looking at a WPS policy. The actual coverage information is included, general information. There's a revision history. We are required to periodically review our local coverage determinations to see if there needs to be an update or a change. Sometimes it's just a real insignificant change, like a typo that we're correcting or a word we left out that we're adding to it. But sometimes there's more detailed changes, and I do want to show you real quick that revision history. Sorry about that, getting behind here. Pulling this back open. The revision history is near the end of the policy, so I'm going to scroll quickly. So if that movement bothers anyone, look away for just a second and I'll tell you when I'm there. All right, I am there. I scrolled near the end of the policy and you can see the revision history information is here. So you can see the date we reviewed it, and then the history explanation and the reason for the change. And you'll see review, review, review. Those are those required reviews that we're required to make. When we make a change to a WPS policy or an update that is significant, we publish this in a news item that goes out to you. And I believe we also publish it on our website. So the LCD that we're talking about today, Psychiatry and Psychology Services, includes references to CMS national coverage. Where does it say that? Right here. And it's also in addition to national coverage, we have information in various CMS Internet-only manual publications. That's what you see here, publication 100-04, the claims processing. 100-02 is the Medicare benefit policy manual. And there could be also other resources that were used for the policy, including the Social Security Act or Code of Federal Regulations. So now we're going to actually start a walk through the policy itself and then the billing and coding articles. Now when you're looking at a policy, I'm going to pull it open here, the policy back open. It is near the end of a policy, remember those start with L, that if there is a related coverage document or an article, right there will be that link. And there, folks, that A57-480, we're also talking about today, is the billing and coding guidelines for psychiatry and psychology services. It's the companion article to this LCD. CMS requires that we include no codes within a policy, so the codes that are for services that are affected by this policy are in that companion article and the billing and coding document. I'm going to go ahead and open that. Remember, look at that contractor information. Make sure you're looking at WPS information if you're a WPS provider. Here's where you're going to see codes sprinkled throughout. There's some codes for CPT codes. And then sometimes some of our billing and coding articles will have a group of CPT codes. There's 25 codes here. I'm going to expand. All of these codes are part of this policy. And then we'll have the group 1 codes and then the group 1 diagnosis codes that WPS considers to be to prove medical necessity. So the group 1 codes are for use with these CPT codes, and here are all the diagnosis codes that we'll pay for. So the coding information is in the billing and coding guidelines, just like it says. Okay. Things to remember. All right, so let's take a look. Let's walk through that policy. We're going to start here with psychiatry services, or talking about psychiatry services with an evaluation and management code. And this is a pretty hot topic. We get a lot of questions about this. It is right within our policy. When you're viewing our LCD, one of the first things you're going to see is the WPS coverage guidance. for psychiatry services with evaluation and management, or what we call E&M. The information on this slide is actually cut and pasted from the LCD. So in our policy, we say that some psychiatry services can be reported with an E&M service when they're being performed. Sometimes an E&M code is used alone, or sometimes it's used with a psychotherapy add-on code. One thing you need to remember is that the E&M service is based on the physician's work, and it includes those medically necessary services to evaluate and treat the patient. Okay, so an E&M service as well as a psychotherapy service on the same day. The policy speaks to that. So there's the blurb at the beginning about doing both the E&M and psychiatry services, or psych service, on the same day, and I did want to point that out. We're going to talk more about that in a little bit. But next in the policy, and what I'm doing is just moving through the policy just as these items appear. The first specific service that is addressed in our policy is the psychiatric diagnostic evaluation. The LCD provides the description. It provides a cross-reference to information about the provision of this service as it relates to nervous system stimulators for chronic intractable pain. And that information is in a national coverage determination. It's titled Electrical Nerve Stimulators. So there's a cross-reference. The rules in the policy apply for both the psychiatric diagnostic evaluation, that includes physical examination elements, and a psychiatric diagnostic evaluation without a medical service. So the rules apply to both. You can find the guidelines about frequency for this service in our companion article, because there is a frequency for this service. The policy states that the same provider cannot report an E&M code on the same day of service, that it can't be billed with a psychotherapy service code on the same day. It also states that it can be reported more than once if a patient has separate evaluations conducted with the patient and with the patient informants, or with, if the provider, I should say, has those separate evaluations. And in certain circumstances, others can be seen in lieu of the patient. The policy tells you that. So this is what defines what WPS considers reasonable and necessary, or medically necessary. And how do we know that the service that you're billing is medically necessary based on the policy? Remember those edits I talked about. There are edits to make certain that this code is not being paid for when billed with an E&M code on the same day by the same provider, and so on and so forth. I mentioned to you the frequency for this service. The companion article actually addresses the frequency for these psychiatric diagnostic evaluations. The same provider can repeat this service, but only if there's an extended break in treatment that occurs, or if the patient rather requires admission to inpatient status for a psychiatric illness, or for a significant change in the mental status that requires further assessment. So it is in that billing and coding article that we state that WPS considers an extended break as about 6 months from the last time the patient was seen or treated for their psychiatric condition. So there is that guidance of what we consider medically necessary. We're going to allow this every 6 months. Now, does that mean that there's no exceptions? No, it doesn't. But what it means is that generally it's going to be every 6 months. And that means that those edits are set up in our claims processing system to deny a second service if it's billed within 6 months of the other psychiatric diagnostic evaluation. Those edits are checking it. Those edits check, is there another provider maybe across town that saw the patient and provided this service? The claims processing system can track all of that, and those edits will keep that service from being paid. Now, I mentioned to you that there's some exceptions where we can pay for that service, that second service. I mentioned that. You know, if an extended break in treatment occurs, or if that patient requires admission to a inpatient status for their illness, or a significant change in mental status requiring further assessment happens. Well, that's not reportable on a claim itself. So what you would need to do when that claim processing system edit denies that second service is you'll need to appeal it. You'll need to explain why or tell Medicare why that second service within 6 months needed to occur. Why was it medically necessary? The same companion article addresses other times that the same provider can repeat the service as it relates to a patient with an established neurological disorder or dementia, and there has been an acute or marked mental status change. Or in those situations where a second opinion or diagnostic clarification is necessary. And the expectation is that this would be to rule out an additional or neurological processes which may be treatable. So I wanted to mention that the article does mention that or provide that guidance for you. Next up is a little bit of information coming from the billing and coding guideline, and it states that the same provider types can sometimes, or that some provider types, not same, they might substitute an E&M code for the psychiatric diagnostic evaluation when the required elements of the E&M are fulfilled. And remember, that's your history, your exam, and your medical decision making. The article also states that E&M CPT codes do not include psychotherapy. So some provider types, what this means or translates to, they may choose, instead of using that psychiatric diagnostic evaluation CPT code, they may use an E&M code instead. What's the upside of that? We're not going to have that once every 6 month frequency parameter attached to it. So some providers choose instead, as long as they're doing that history exam and medical decision making, to bill that code instead of or in lieu of the psychiatric diagnostic evaluation. The next item addressed in the LCD is interactive complexity, and providers can use an add-on code to represent the increased work intensity of a psychotherapy service when there are certain communication difficulties during that psychiatric procedure. It does not, however, change the time for the psychotherapy service. Okay? It means that that beneficiary has a communication disorder. There is an increased work intensity for that psychotherapy service because of that. So it is in the coding and billing guidelines where you can find CMS's list of 4 communication factors that may complicate the psychiatric service. Only one of the communication difficulties needs to be included in the documentation. Okay? And that is in the billing and coding guideline, and I want to show you where to find that. I'm going to go quickly to the top of this document. You can do that by clicking on the arrow versus scrolling. And the communication disorders for interactive complexity are listed right here within the billing and coding guideline. Okay. It may be reported that add-on code for interactive complexity can be reported when at least one of the following communication difficulties is present. It doesn't mean because somebody else came to the psychotherapy session. It means that there is increased work due to one of these communication difficulties. And of course, the expectation is we would see that communication difficulty within the medical record, that it would be included in the documentation. So we would expect that, those records are going to show why the patient being evaluated doesn't have the ability to interact through normal verbal communicative channels. Now, the record would show the adaptations utilized in that session, as well as the rationale for employing the interactive techniques, and also recommendations for future care. So the record must include all of this information here. One of the questions that we get about interactive complexity deals with an interpreter. I'm just clicking back there to see if I had it listed on a slide, but I don't. It does state interpreter in the when the policy addresses this, and what we're talking here is not an interpreter because the patient speaks a different language than the physician. For example, English to French or French to English. What we're talking about here is interpreting another language, such as, and a friend of mine shared this, and I stole it from her, another language such as Klingon. That's what we're talking about here. The Americans Disabilities Act actually requires that a provider have an interpreter available, and you can't bill the patient for that, but you can bill this interactive complexity code when there is a communicative disorder uh, based on the fact that the patient speaks that different language, such as Klingon. Right. We talked about, or I talked about interactive complexity. I do want to talk about psychotherapy next. The policy provides a description of psychotherapy. We also address maintenance. It's in the policy. Providers must meet and exceed the midpoint of time in the CPT code description in order to report the psychotherapy service. We call this or it's known as the CPT time rule. In other words, less than 16 minutes of psychotherapy is not billable. Remember, you need to meet and exceed that midpoint range listed in the in the procedure code description. Okay. Maintenance per se, is not covered. Helping a patient maintain his or her highest level of functioning, such as a patient with borderline personality disorder, may be covered on a case-by-case basis. And these case-by-case considerations must be supported by the evaluation and a plan with clearly identified goals. So we do receive a lot of questions about maintenance, and I'm going to be showing you in a little bit the documentation requirements to show that it's not maintenance, or what's needed to show that these services are not maintenance. And I'll point those out to you in just a little bit. But I do want to talk a little bit more, and I said I would, about psychotherapy and E&M on the same day. This information actually is within the policy also. We do get a lot of questions about billing psychotherapy and E&M on the same day. The LCD does address this. Additionally, billing guidelines are included in that article. Documentation for psychotherapy and E&M on the same day needs to be distinct and separately identifiable. A separate diagnosis is not needed. You can or should consider the use of a modifier to avoid bundling of payment if your documentation justifies it. Your handout includes an embedded link to our Medicare modifiers webpage. So here's what's included about psychotherapy and E&M on the same day. This is from the Billing and Coding Guideline, and this is what addresses significant and separately identifiable. Sometimes separate diagnosis, sometimes not. It's not required. It also addresses site of service, which is no longer part of the CPT code descriptions for psychotherapy. So we've included that information within the E&M or the Billing and Coding Guidelines. Here's the deal. A provider cannot include the time spent of the activities of the E&M service when reporting the psychotherapy service. So in addition, when you're billing for E&M and psychotherapy, time may not be used as the basis for the E&M code selection. Okay, you need to choose the E&M code based only on the level of medical decision making. Okay, that's what the policy says. We need to look at that documentation and see you spent this much time on the medical decision making, but you can't choose your code based on time. We would choose the code based on the level of medical decision making, but that you didn't overlap time when you reported the minutes for psychotherapy. The services can't overlap. So documentation requires distinct, detailed notes for the medical evaluations and for the therapeutic interventions. The appropriate psychotherapy add-on code is then selected based on that face-to-face time of the psychotherapeutic intervention. The code closest to the actual time of the service should be the one that's reported, and do not include any of the time devoted to evaluation and management, history, exam, medical decision making when choosing the codes to report your services. Okay, you're going to look at the documentation based on the medical decision making, and you can't overlap your psychotherapy time with your E&M service. Here is information from the coding and billing article about choosing the correct code to report psychotherapy. This is what I just talked about. You can report psychotherapy without E&M services, and then of course you can consider using the add-on codes if you're going to report psychotherapy with E&M services. There's that add-on code. I want to talk a little bit about psychotherapy for crisis. That's the next item listed. The LCD addresses the addition of codes for psychotherapy for crisis when the psychotherapy services are provided to a patient who presents in high distress or with complex or life-threatening circumstances that are going to require immediate attention. And this should be evident in the documentation. These codes do not include medical services. In a crisis situation, psychiatrists, who are MDs, may prefer to choose the appropriate E&M code and bill it instead. CPT codes for psychotherapy for crisis are time-based. The coding article states to report 90839 for the first 60 minutes and then report 90840 for each additional 60 minutes, and do not report psychotherapy for crisis with any of the codes shown on the last bullet of this slide. Okay. And again, how will we keep that from making payment, or that claim from making payment, if you do report psychotherapy for crisis with one of these codes? It's those edits I talked about earlier. CMS recently, within the last couple of these years, created a couple of new HCPCS codes, G0017 and G0018, to report psychotherapy for crisis in a non-facility place of service. And this slide does include place of service 3, which replaces place of service 2 in sub-bullets. So I've corrected it. What I'm talking about is right here, folks. I believe on the handout it was 02, and we didn't realize the typo until after this was published for you. Oh, click too hard there. So what I've done here is I contacted our system staff to get a list of valid places of service for those 2G codes. They're listed here on this slide. So 90839 and 90840 are used when the services are furnished in a non-applicable site of service. And the G0017 and G0018 can be accepted with these places of service here on this slide. I want to talk about family psychotherapy, and this is to assist in the diagnosis and treatment planning. Sometimes the provider needs to contact family members or others in order to get needed information. WPS does include family psychotherapy guidance in the LCD. It is covered, but only when the primary purpose is for the benefit of the patient. And there are examples listed in the LCD. So codes for family psychotherapy are shown here on this slide, and these shouldn't be used for taking a family history or for evaluation and management counseling services. And do not report family psychotherapy for supervision of therapy with professional caretakers or staff. So some information specific to family psychotherapy on these slides. The policy states for family psychotherapy, the time may include face-to-face with the family members as long as the patient is present for a part of the service. I wanted some clarification on this, so I asked our contractor medical director for clarification. The CMD did confirm that the exception to this is when reporting CPT code 90846, which is used to report family psychotherapy without the patient present. So for that code, the patient wouldn't be present, and that's okay. Group psychotherapy. This policy includes description for group psychotherapy. It also includes what we will consider, or that we will consider payment when the group is led by someone that's acting within their state scope of practice, and only when that group size is that of a size that can be successfully led. The policy states this is 12 people. So more than 12 people, WPS is not going to pay. So So based on the information in the companion article, WPS will also consider payment when that interactive complexity add-on code is reported with group psychotherapy. Now be certain that your documentation is going to list that those communicative disorders or that communication disorder that makes that extra work billable to Medicare. Okay, so you need to make certain that's included. There are limitations for psychotherapy included in the policy, and these are the requirements that we use to consider whether psychotherapy is medically necessary and eligible for payment. They're listed right here. These are just some of them. There are more in the policy, so look in that policy to see the limitations for psychotherapy. Let's talk documentation for psychotherapy. This is a entry-level presentation today, but I'm going to hit the important bullets and information for you. So in addition to limitations for psychotherapy, our policy staff includes, right in the policy, the requirements for documentation for psychotherapy. Okay? When providers ask me what WPS requires in the documentation for psychotherapy, this is what I show them. It's right in the policy. Okay, so what are the documentation requirements? This is the billing and coding guideline. Let me go to the policy real quick here. L34616. Remember, I'm a searcher, not a navigator. So I'm opening that policy. You have links to all of these within your handout materials. Here is the policy, the LCD. And I told you that the documentation requirements are here in the policy. So if you ask me what needs to be included in the documentation, I'm going to tell you this right here. Must indicate the time. I've gotten some questions about time. Time in exact minutes. We don't make you choose one way or the other, or we do allow you to choose how to document the time, but it has to be exact minutes. 39 minutes. 57 minutes. Start time 9:02, end time 9:58. Either way is fine, okay? Behavior modification is not a separate service, it's an adjunctive measure. There's expectation that there'll be of goals, the progress toward those goals, and an updated treatment plan in that medical record. If something's not working, why is it not working? What are you going to do instead? What is your plan? What is the updated treatment plan? Prolonged treatment must be well supported by the content of the medical documentation. Documentation must be present in the record that supports why that ongoing treatment is medically necessary. Why is it necessary that this continues? To establish medical necessity, of course, the claims must be submitted with a covered diagnosis, and that is included in the billing and coding guidelines, those covered diagnoses. So that's documentation for psychotherapy services. Our policy staff put this into the policy specific to psychotherapy services. If you move to the end of the policy, there is some general information here for documenting services. The medical record has to document target goals, goals of therapy, why that chosen therapy is appropriate in lieu of or in addition to another form of psychiatric treatment. Needs to fully support medical necessity. Documentation includes but is not limited to the relative history, physical exam, and so on and so forth. It also talks about the fact that we expect your medical records are going to document the patient's capacity to participate in and benefit from psychotherapy if psychotherapy is the chosen treatment. If the patient has a diagnosis that wouldn't support the fact that he or she will participate in that therapy and benefit from it, then WPS is not going to consider that it's medically necessary. Okay? More information here. Documentation must be available and requested prior to payment, and may be requested rather prior to payment. If that claim does not indicate documentation is available, it will be denied. So make certain that you are filling out that field on the claim form that says I have documentation available upon request, should we need to request your documentation. So general documentation requirements. and documentation for psychotherapy. Right in the policy. This is where I point when someone says, what do you expect? Can you give me an example? This is what you need to include in your documentation. Show this to your providers. This is what WPS wants. Okay. So just some good information there on the documentation. I do want to mention that one of my colleagues who is a clinician is offering up some presentations where she dives much deeper into documentation for individual psychotherapy and for group therapy. Take a look at the recordings on our YouTube channel because that information is available. I believe she has already hosted both of those sessions. If not, they'll be coming up. You know, check out the new webinars that we're hosting. Take a look periodically out at that YouTube channel to see those recorded sessions. Deeper dive. This is entry level only today. All right, I want to talk about narcosynthesis because that is also included in our policy. And like other services that are covered by our policy, the LCD does include a description of narcosynthesis. The policy tells you that in order for us to cover this service, the provider must document medical necessity, and specifically what we're looking for narcosynthesis, the documentation, is you need to document why the patient had difficulty verbalizing his or her problems without the aid of the drug. The LCD further states that you need to include the name of the drug, the dosage listed, and whether that was or was not effective. The treatment, whether the treatment was or was not effective. You need to include all of that in your documentation. It is in our policy that you'll also find that WPS payment for narcosynthesis is restricted to physicians only. This means MD or DO, Doctor of Osteopathy. Typically it would be the medical doctor, MD. We include coverage parameters for hypnotherapy rather, not hypotherapy. It mentioned at the in the policy, this is the last service that's mentioned in the policy, it's hypnotherapy. We once again describe the service and we state that it can be used for either diagnostic or therapeutic services. The policy also states that it must include a covered diagnosis. So you can find covered diagnoses for hypnotherapy, that's CPT code 90880, in the Group 2 list of covered diagnosis in the coding and billing guidelines. We have a Group 1 list. I showed you those earlier. There's 25 CPT codes. When you bill one of those codes, you have to have one of those diagnosis codes in order to show medical necessity and be covered. So says WPS in their local policy. There's a separate list for just this one single code for hypnotherapy, 90880. It's the Group 2 list of covered diagnosis that we will make or allow payment, consider payment for hypnotherapy. So make certain you're looking at that correct list. I got behind on my slides here. I apologize for it. Biofeedback, for those that provide this, I do want to mention that the related national coverage documents found under associated documents near the end of the policy does provide a link to that NCD, Chapter 1, the Medicare Coverage Determinations Manual, so you can find details about biofeedback therapy. It is Section 30.0, excuse me, 30.1, and I have included a link to it if you're billing those services. The coding and billing guideline also provides guidance about some other CPT codes that fall within those mental health, that fall within that mental health section of the CPT manual, 90885, 887, and 889. These are services that are not separately paid by Medicare, and the billing and coding guidelines tell you that. So the documentation requirements, as I mentioned, I already showed these to you because it was more convenient to show you while it was open. They're there. They're right in the policy. And remember, we have separate, we have additional, I should say, documentation requirements than for psychotherapy. So these are the items and services we covered during this session today. Why is medical necessity important? Remember, it needs to be otherwise covered by Medicare so Medicare can consider coverage. We talked about a high-level discussion of the local coverage determined in that billing and coding article. A lot of good information in both of those. I do want to mention that coming up later this month is a mental health playbook session for same-day billing guidelines and bundling. Look for the webinar announcement in eNews and on our live events webpage. And of course, this is the third of 12 events, so we have several of them coming up. Before I open for questions, I do want to mention to you that this slide was inserted after the presentation materials were posted because other staff at WPS asked us to share information about overpayments with you. Specifically, the ways that you can return an overpayment to us when you discover it on your own, or set up a request when you discover that overpayment. So providers are required to notify us of overpayments and repay us in a timely manner. So here are some links to some helpful resources. Of course, the self-service tool SNAP, our secure net access portal, is the preferred option. It's more expeditious than using paper. Because this includes links and this slide is not in your handout, what I plan to do following today's event is send you this slide, this one single slide. And that brings us to just a little bit of time for questions and answers. And I did see some popping up. I can't read the chat while I'm presenting because I'm, sharing this full screen. Karen, do we have some questions, or do we have so many that we're going to want to publish that Q&A document following our event today?
Mary, thank you for all of that great information. Actually, we do not have any questions yet from anybody, so if there are questions, please add those into the chat.
Wow. You all did such a great job submitting your pre-submitted questions that I can include the answers to a lot of those questions I got in advance. And I did send out an email yesterday for those questions that really didn't pertain to what I said I was going to talk about today. I did provide you with some resources or help, or where you can go for some help. But you will have an opportunity. If you are like me and you forget to, you think of a question later that you wish you would have answered, I'll tell you how you can do that. But first, I do want to remind you that we do have a survey available. We want you to complete this survey and provide feedback to CMS about this experience with WPS and with experiences with other WPS departments as well. We want to know, and CMS wants to know. Your feedback is really valuable. You can use the link in the chat, or when you exit the webinar, you're going to have a pop-up that looks like what you see on the right top side of the screen, that yellow triangle and blue button that says continue. That's just a pop-up that WebEx sends out when you exit our webinar to say, hey, you have one last chance to take the survey if you've not already done it. Some of you may be looking for CEUs, or continuing education units. In a few minutes, you will receive an email from WebEx, not from WPS, and included in the body of that email is language that serves as your certificate of achievement. It's not a separate attachment. It is an email that includes the name of today's event, the contact hours, and the date. The email is what you need to send or present to that accrediting body of your choice so they can consider awarding you with CEUs. WPS does not do that. Now, if you're not watching, or if you are not watching the slide presentation, I should say, and you joined by phone only, you're going to receive a different email from WebEx. They're going to say, sorry, we missed you, because if you joined by phone, they have no way of knowing it was you. You didn't provide your phone number when you registered for our webinar. So what you'll need to do if you need CEUs and you joined only by phone and followed along with that handout is you're going to need to send an email with the CEU, or you're going to need to send an email to us asking us to award you or not award you with CEUs, but give you that certificate of achievement. Send an email to wps.gha.education@wpsic.com. Include your 10-digit phone number. We'll check it or verify your attendance with our attendance records from WebEx. In that email, include the name of this event and the date, and WPS will then send you an email with verbiage in the body of that email that provides your certificate of achievement for attending this program today. Now, if you have a question that we haven't gotten to, we're right at 11 o'clock. We will accept event-related questions or topic-related questions for 7 days following this live event. The questions must be received by noon on the 7th day. Send the email to that same email box you heard me talking about. That is our education mailbox. It's used only when I ask you to send me something or when you have a question about one of our programs. What time is it? Is it virtual? All of our events are currently virtual, but you might have a question about one of our education events. It's not the same as sending a question to customer service. If you have a claim-related question, that needs to go to customer service. This is our education mailbox. At this time, on behalf of Karen and myself and all of Provider Outreach and Education, I do want to thank you for attending our webinar. We do look forward to your survey comments or your survey completions, and we will hope to see you at a future event. If you placed a question into the chat after I asked Karen if there were any questions, you can be certain that I will respond either directly to you or I will create a list of questions and answers and send them to everyone. This does include our webinar. You may now disconnect. I hope all of you have a wonderful day. Thanks, everyone.